Okay, let's go ahead and get started. I'm just going to kick off the general session. As you know, this is the second of 3 weeks of interns presenting what they did on their summer vacation. And so I will let one of our esteemed faculty, Lisa Karstens, introduce her intern.
Hi, I'm happy to introduce Bryn Hester. She is a rising sophomore at Middlebury University, all the way in Vermont. Right? She's done a lot of great work this summer, and I'd like to just also point out that 2 years ago, she actually did a internship with me as part of a high school program for the Partnership for Scientific Inquiry, where she actually recruited or helped with recruitment for a lot of the participants that she's now analyzing the samples for.
All right, thank you for that introduction. So my name is Bryn Hester, and I'm going to be presenting on comparing methods of metabolite identification. So first, I'll give a brief overview of the study as a whole, showing where my piece fits in. So I'll talk about overactive bladder and the urinary microbiome and metabolome. I'll talk about the methods available to identify metabolites, and then I'll compare those methods and talk about what's next. So this is just a general overview of the research that's done in the Karstens group. My project looks at a very specific component, but I wanted to show you where my component fits in. So overactive bladder is associated with issues of storage, including symptoms such as increased urinary frequency, increased urinary urgency, and urinary incontinence. These lower urinary tract symptoms are not just associated with infection, though. So that means that people can have these symptoms without having a UTI. Also significant to note is that these symptoms are highly prevalent in the population of women over the age of 40, as it's shown here in the table. While these symptoms are highly prevalent, they are not well managed, and there is an interest in figuring out what the underlying cause is. One of the areas of research currently being investigated is bacteria in the bladder and how that might relate to these symptoms. So this study compares the urinary microbiota and bacterial products between 3 groups: OAB wet, OAB dry, and controls. So OAB wet is those with the lower urinary tract symptoms with leakage involved. OAB dry is those symptoms without any leakage, and the control shows no signs of symptoms or infection. And so this study is really comparing the microbiota and the bacterial products, or the metabolome, of each group. And this is done using urine samples from the patients to analyze these different compounds and bacteria. To look specifically at the bacterial products, metabolomics data is used. And this is collected through nuclear magnetic resonance spectroscopy, or NMR. So when analyzing metabolomics, you begin with this output from NMR, which are labeled as spectra. So each sample has its own spectrum that can be plotted in this manner. And as you can see, there are different peaks that differ between each sample. These peaks are related to specific metabolites, and they can be identified and then quantified. As you can see here, this sample has a peak here that this sample does not, and therefore this sample would have that specific metabolite, whereas this one would lack that metabolite, and we can see that through our analysis. So before the metabolites are identified and quantified, there's some pre-processing steps that must take place, and these include normalization, baseline correction, peak alignment, and phase correction. After these pre-processing steps are taken, we move towards the identification and quantification steps, which involve ideally an output that looks like this, where we have metabolites and their corresponding concentrations for each sample. From there, we can perform analyses and compare the metabolites from each group and their varying concentrations. This can then be mapped onto our microbiome analysis as well. So I specifically looked at this step here, the quantification and identification step, this summer. I also did a little bit of the pre-processing step, as it is sometimes involved in the programs that do quantification and identification. So to do this, I looked at 3 different programs. One is Kinetics, which is a closed source software that is considered really the gold standard for metabolomic analysis right now. But in a call for more open source materials, there are two new open source programs that are run through R, Asics and Batman. And I really wanted to just compare how these programs analyze the data. And so to do this, I looked at accuracy, automated runtime, and user interaction time. So to look at accuracy, I looked at our original spectrum here and what the program suspected was there and what they fit and quantified. So as you can see here, these blue peaks, these all belong to one metabolite, benzoate. As you can see, it matches the original spectrum in black quite well. And therefore, we could presume that that is an accurate fit for what the program has quantified. Whereas this red peak here, it is not fit well. As you can see, it doesn't match up with the peaks that it is assuming is there, and therefore that quantification would not be an accurate fit. Automated runtime really gets down to how long the computer has to run and how much processing power is required. This is considered a hands-off time, but still important to take into account when looking at programs. And then user interaction time is more related to the manual input that is required of a user when interacting with a program. So the first one I'll talk about is Batman, which stands for Bayesian Automated Metabolite Analyzer for NMR. And this is an open source program run in R. There's one function that's run in MATLAB, but that's technically a pre-processing function that's optional, but I just would like to know that because MATLAB requires a subscription, whereas R does not. It was published in 2012 with a refined protocol in 2014, so it's been available for quite a while now and has been used in over 98 publications. Another thing to note about Batman is that it requires your data to be pre-processed, except for that one step in MATLAB. It requires that of the user to have pre-processed data. So Batman uses a target list to assign metabolites to peaks and then obtains relative concentrations. And this is all done through statistical modeling. One thing about Batman is that its automated runtime really depends on your number of samples and the number of metabolites you want to fit. While Batman has the option to look at over 100 metabolites, the runtime really is dependent on you having a low number of metabolites, and it was initially designed for only tens of spectrum, so tens of samples. So when you input more, it will take a long time, and the accuracy is not as reliable. Some manual aspects of Batman, while it's very automated, it still requires the user to change the target metabolite list and the parameters manually and outside of the program itself. And then the code itself is very simple. It's one primary function that allows you to both quantify, identify, and plot your reconstructed spectrum all in one. So that allows it to be very simple and straightforward. So here is an example of a spectrum in Batman. And so in blue, which is mostly covered up by black in this image, is our original spectrum, and then this green line here represents what Batman is fitting as metabolites there. So as you can see, it does not match up very well, and so we presume the accuracy not to be very well. The one thing about Batman, though, is that this is not an ideal list of metabolites used here. Because it only allows a few metabolites for it to not have a long runtime, it is not the best representation of its possibility. So some takeaways from Batman. It's automated. It has a very simple code. The ability to create a specific metabolite library is also important. Although while it has 100 metabolites that you can input, you can also add your own very easily through your own resources. However, it does have a lengthy automated runtime and requires a lot of processing power. The pre-processing does have to take place in another program. And these manual portions of target list or target metabolite list manipulation are error prone. And also the inaccuracy of identification of metabolites is another thing to note. Okay, so Asics is the other open source program I looked at. It's also run in R. This one, however, is very new. It was first published in 2017, but it wasn't really refined and edited until April of this year, and many of the documentation aspects and tutorials weren't put up until June. So it's a very new program, and with that, it has some room for improvement. This program does include pre-processing functions, unlike Batman, and then it does have a quantification of metabolites, of course, post-quantification analyses, and target list adjustment. And this one was specifically created for biological mixtures. So with Asics, I really wanted to look at the pre-processing functions because it was unique to this program. And so I really focused in on normalization and binning because there was a lot of different options and variations in how you could do it, and I wanted to get behind what the program was doing. And so I looked at different methods and different orders of doing this, and I ultimately found that as long as it was done before quantification, there was no real effect shown on that aspect of it. Asics has a moderate runtime for the quantification step itself. However, with the pre-processing, the timing can be in flux a little bit more. And a lot of the interactions, unlike Batman, are directly through R instead of taking it outside. So that was the difference between the two of them. So here is an example of a reconstructed spectrum. And this is just a zoomed out image of it. And as you can see, it looks like a relatively good fit. The black line, which is the original spectrum, looks to fit the blue line fairly well. However, when we zoom in and look at this same region of benzoate, you can see that while there are some peaks that may be in the right area, they're not at the right height, and also these peaks over here probably correspond to other metabolites and therefore do not fit, are giving us quantifications for metabolites that aren't actually in our original spectrum. So some takeaways from Asics are that has pre-processing functions. There's very little need for manual input, and has a moderate amount of runtime. However, that is kind of a qualitative assessment of it, so it's not super precise. It doesn't have super accurate identification of metabolites, and the documentation is minimal because it's a new program. There's very little online about it, and not as many resources for a user. Okay, so finally I'll talk about Kinetics, which is the closed source program that is on its own software platform. There's a cost for the full access. Unlike Asics and Batman, which have around 100 metabolites, Kinetics has over 300 metabolites to match peaks with. And what's unique about Kinetics is that you are directly interacting with the fitting process. Unlike Asics and Batman, which have statistical modeling behind it and run it on its own, the user is directly interacting with Kinetics to fit each peak specifically. And Kinetics also has pre-processing functions, but due to timing, I did not look at those this summer. So I looked at different ways to use Kinetics. There's several different ways to match these peaks. So I went through and identified each individual metabolite to see if it fit in the range. I also used a targeted list, so looking at what would be more likely found in urine, so I wouldn't have to look through all 300 metabolites. And then also searching at specific ppm ranges, so specific ranges on this x-axis to see if there's any fit with a peak that exists in your sample. And something I'd like to note, I used the free trial version this summer, so my interpretation of Kinetics may differ a little bit than what the full version offers. Here's just a broad range to show the overall spectrum, but when looking in on one specific range, this is benzoate again, you can see that these were all matched, and this is all done manually. So this is done by a user interacting directly with the program and the sample to fit it. So pros of Kinetics is that it has accurate identification of metabolites, and there's lots of transparency in that. You can see directly how your quantification is interacting and fitting with your original sample. There's also a high number of metabolites available, which is definitely convenient and also helps down the line. And the reproducibility aspect of it, though, is definitely a con. These manual aspects and user-intensive processes like this definitely have error and are not easily reproduced by another person. It's also costs money and is a closed source, which does not allow it to be the process to be looked at again very easily. And it has very lengthy user interaction time. It can take several hours up to a day to analyze just one sample, depending on the method that's used. Okay, so just to summarize, this is a little summary table highlighting the differences between all of these programs. And something I'd like to note about all of these programs that they all gave us an output of metabolites and their relative concentrations. So we were able to obtain that table that could be used for analyses, but looking at the accuracy is really what prevented us from doing that, because as you can see, these two programs are not accurate, and then this one's not open source. So there's not really something that hits all the boxes. Okay, so looking forward, if to use Kinetics, there would need to be a developed protocol. To validate user fits, there would have to be probably at least 2 people looking at each one to really confirm the metabolites and their fits. And then another possibility is to work with open source programs more, especially the ones that I mentioned here. Especially Asics, which is new and has room for improvement and is still has a lot to possibly be built up. Additionally, because my time this summer was short and I didn't really get to spend a lot of time thoroughly with each program, there's definitely room to optimize use with each of these programs. So it could be a matter of just making sure that parameters are set correctly and just understanding the program at a deeper level. Another option is untargeted analysis, which takes a totally different route than what I've explained today. It looks at just the peaks that differ amongst samples, so finding metabolites of interest and seeing how they differ amongst groups. I'd like to acknowledge my mentor, Dr. Karstens, the DMICE internship program, and the National Library of Medicine grant. Thank you.
Thanks. That's interesting. Do you believe that things could be done in a way that would make those open source programs more accurate? Or if not, is it even worth bothering with them, since accuracy is so important to research?
Like I kind of mentioned right at the end, there's definitely room for optimizing the use of it. So it could be just a matter of like how I was using it and how it was intended to be used. So it could just be a difference of that, which I do think is worth putting time into, especially since Kinetics itself has a lengthy manual input time and, like I said, is not as reproducible. So I think there's definitely a benefit to putting some effort and investment into these open source possibilities as well.
I would just like to add that I think a big improvement to these open source packages would be having some sort of measure of goodness of fit, because as she hinted to at the end, all of them produced a table which you could blindly go and run with further analyses, and nothing, I don't think there were really any anything that indicated like you should do a sanity check and look at the fit of the metabolite, right? So you could really like incorrectly, accidentally run with data, which is a danger. But I think like having a goodness of fit measure or something could help you realize that, oh, this needs to be improved better.
It's a little disheartening that the open source tools seem to be so bad. Did any of the publications that use these open source tools talk about issues with accuracy or identifying, things in the samples that they expected or that they didn't expect, or, I mean, I've had some similar experience with proteomics tools where there's all these tools out there, but you can't possibly figure out the magic incantation of parameters to set to get reproducible results. So I wonder if it's in that kind of state, and if some people who've worked with this have, for whatever reason, maybe they talked to the authors or something, figured out how to use it in a productive way, or if that's just a common problem in the state of the art right now.
Yeah, let's see. Yeah, it's interesting that you note that like the magical parameter mix is definitely in there. And I think also something that is important is looking at like what type of data this was originally created for, too. That's part of the difficulty with this is when looking at other publications, they might be using other sample types, which involves a whole nother set of parameters and objectives. But I didn't really notice anything specifically in the literature that like was analyzing how well these worked for them. There was a couple articles comparing different methods. There's a couple other open source things available. But yeah, I'm not totally sure exactly what the answer is to that. Yeah.
Is there any publications that evaluate the accuracy in comparison, sort of like you did, but maybe more quantitatively?
There's a couple that have like kind of touched on that, but not kind of as directly, maybe as you're suggesting.
I don't think any have looked at Asics because it's so new. And I know Batman has been evaluated. It would be interesting to see those 98 publications that have used it, how many of them include the authors that created Batman. And it could be that, like, I mean, it could be a technicality with the NMR. Like, it might be, like, the spectrum that it was built on and used might have used one certain, like, type of pulse sequence, which is instructions on how to acquire the data, and we might be using a different one. But that would be really under the hood. So I don't know, that there's been, like, really robust benchmarking manuscript or anything yet. And specifically for urine, which is another thing.
Well, I've got the pleasure of introducing Michael Abbey, who's our second speaker, and I'm doing this really on behalf of Michelle. Michelle and I are working with Michael together. And so Michael was a local kid. He grew up in Portland and went to Lincoln High School. And he is now about to start his sophomore year at Case Western Reserve University in Ohio, where he's studying biomedical engineering. And in the group, like Michelle's been doing a lot of work involving sort of data analytics and big data, and she's been working with Adam, Adam Rule, who many of you know, who's the starting NLM postdoc. And as part of that, Michelle recently wrote a grant involving sort of clinical quality measure extraction from the EHR, and Michael will talk about why that's important from a technology perspective and a clinical perspective and a policy-making perspective. But really what I want to do is just say that he's done a great job this summer. He's been real fun to work with and, a really nice guy. And so if you can please help me welcome Michael Abbey.
Thank you. So I am doing an EHR data assessment. I'm evaluating the quality of electronic health record data and its fitness for secondary research. So first off, I'd like to thank the National Library of Medicine for providing me the funding for this internship to be able to conduct this research. But diving right in, talking about secondary data. As some of you are wondering what that are, secondary data is EHR data that was initially collected during clinical care and reused for different purpose. So I'm assessing this data in the lens of a data fitness aspect, as to whether this data is able to fulfill a particular role or task. In this case, I'm evaluating it through the role of clinical quality measures. Other potential uses could be for research or public health data. Now, if you're wondering why this is important, it's because EHR holds an immense potential for secondary data reuse. And specifically, it's valuable in comparative effectiveness research, as clinics and providers can look at treatments in different settings and compare the results and how that may lead to different outcomes. So regionally or clinically, different ailments or diseases can be treated in different ways. So if, for example, a treatment in one area can be treated with conservative ambulatory care, or in another case it could be a surgery operation, and evaluating the results and how these played out can provide valuable research into every aspect of medicine. As well as many subspecialties don't always have generic practices, and different medications and procedures can be given to different patients in different stages of treatment, and evaluating individually on a basis of how well all these factors implement healthcare is very important in the future of medicine. So the key aspect that I was evaluating from is the EHR, which is electronic health records. So in the era of large-scale health data research, data is increasingly important, and it has incredible potential for reuse in many fields. Over the last decade, the country has undergone a massive transition from paper to electronic health records, which have helped to improve efficiency, quality, and safety of a very large quantity of health data, as well as providing the opportunity to store these quantities for potential reuse in the future. Now, one of the main benefits for this is that it can reduce the cost and inefficiency of clinical research by cutting down the patient recruitment and data collection processes, as all this data is stored within the records, so all you need to do is pull out the data and analyze it. And similarly, the data is diverse and all-encompassing, meaning that certain clinics or providers would have access to data and records they may not have otherwise. As unique or rare cases, data can be readily available on a large scale. However, there are many concerns regarding the EHR data as well, the primary being that the EHR data records may be attributed to an increase in quantity of data rather than quality. So the data recorded in clinical settings isn't held to the same standard as data recorded in a research setting. So there are initial concerns that data not recorded for intended research purposes may pose issues later on, negatively impacting research results, as well as that the EHR is supposedly optimized for efficient patient care rather than in recording results with a specific manner. Additionally, in large-scale studies, there may have been high variation between clinics and even between providers and clinics, so analyzing this data on a large scale may have high variation just between these various cases, further skewing the results. Additionally, with the increase in EHR, many providers saw an increase in recording time, which is difficult for providers as their payment is based on quantity of patients seen, and therefore their income is based on how quickly they can see patients. Ideally, providers would have high quality and high quantity patient care, but this may not always be the case. And in certain aspects, in the matter of saving time, the patient care is kept at a high standard, but the recording may fall short in some areas. Additional issues with the EHR is that there are reports that it's difficult to use, require too much time, and it can cause confusion in going through unfrequent tasks. Additionally, cluttered displays can also cause recording errors, as well as the fact that inconsistent terminology within the EHR and within assessing the EHR causes difficulties in analysis of the data. So some of the previous findings on EHR. There's been a lot of research in the last few decades as EHR becomes more readily available. A study in 1997 found that between various fields within the EHR, there's anywhere from 44 to 100% correctness and 1.1 to 100% completeness. Similarly, 6 years later in 2003, there was a sensitivity value of 26 to 100%, which is a similar metric that they use to calculate basically completeness. And additionally, 7 years later, 0.1 to 51% completeness of blood pressure readings. Now, the issue with this is that all of these studies are basically attempting to assess the quality of the EHR data. However, there is no gold standard, no generic method to assess this, and as such, there are many different terms and assessment methods used to evaluate these potential fields, such as correctness, completeness, sensitivity. And even so, there is no gold standard to determine whether or not the data is actually correct and complete. The most common method is comparing electronic health records to paper records. And even so, there's no guarantee that these paper records are any more complete or any more accurate than the electronic ones. So this brings me then to the terminology and framework developed for assessing the EHR data. So a study by Nicole Weissop recorded that there was high variation and overlap between the terms used in discussing the data research. So as you can see on the left side of the figure here, these are the various terms that were used to record basically data quality, and these are the various methods they used for assessing that. So as you can see, completeness and correctness are pretty common gold standard references, and data agreement are also pretty frequently used terms. However, there's still a great deal of variation and obscurity within these data sets. So that brings me to a study in 2016 by Kahn, which sought to harmonize the data terminology and create a framework for assessing EHR data. And the three main categories that it was broken down into was conformance, completeness, and plausibility, of which those are the three that I chose to evaluate for this study. So conformance is basically the consistency of the data to adhere to standards and rules in each of the data fields. An example of this would be race would be described as one of the 6 standard categories, or sex would be either the character M, F, or U. Completeness refers to the values being present within the data fields. So for example, a patient with glaucoma would have an IOP value for visit days for every time they showed up. And plausibility refers to the believability or the correctness of the data. So a patient with low vision going for refractive surgery would not be expected to have a visual acuity of 20/20. So for this study, I'm assessing conformance and completeness for each of the data fields in each measure, and plausibility as it pertains to the measure, as in many cases there's high variability and the metric may not be extremely reliable. And even so, the completeness and conformance categories are assessed for every data field in the measure, whereas plausibility is assessed by the patient and the metric outcome. So this study is conducted at KCI Institute using ophthalmological data from OHSU, and as such, it uses EPIC and to pull the EHR data. So basically, what I'm looking through for my lens to evaluate this data is our clinical quality measures, which are set out by the American Academy of Ophthalmology, or the AAO. These quality measures are used for merit-based incentive payment system, recording clinical data measures for Medicare and Medicaid reimbursement. So within the era of Obamacare, there's now been more of a move to have providers being paid on quality, not necessarily quantity. So these measures provide the outlet to assess quality of patient care. So through the AAO, there are access to subspecialty-specific clinical quality measures that are optimized for relevant clinical care. Specifically, the IRIS Registry Intelligent Research Insight helps to subset some of these issues in data quality, as providers have complained that measures are not necessarily relevant or there's not enough data within their subspecialty fields to report on them. So I'm using 3 measures through the IRIS to do this. And the clinical quality measures themselves represent broadest number of subspecialties, diagnosis, and treatments, which are compiled by various specialties or by various specialists within these specialties, and they agreed on the best methods to assess the common treatments and the outcomes of those. So what the actual measure looks like in its breakdown, as far as the data used, they were primarily drawing from 3 different fields, the first of which is billing data. So this would be things such as CPT codes, which are basically procedures. So if you're at the hospital, what you're actually having happen to the patient, what procedures are going on. Second of which is ICD-10 codes, which are the diagnoses. So if they're at the hospital, if they're receiving care from a provider, what they're actually receiving care for. Next is visual acuity data and interocular pressure, which are types of exam data that would be recorded by the providers at the visit. and similarly, patient data, which would be age, dates, and history. Additionally, what the measures look like individually is that they're broken into a numerator and denominator. As you may recall from elementary school, the denominator is basically just everything that's included. So if the measure was looking at refractive surgery, then it would be all of the patients who had this refractive surgery. And the numerator would be evaluating, out of the patients with the refractive surgery, how many met this certain criteria. So the way I actually began to design this project was I would start with selecting a quality measure. I tried to choose some from the 2019 series that covered a various spread of data quality issues and data fields. Then I would map the fields in the EHR and extract the data identified in the measure, making note of missing fields or fields that didn't have great data. Then I would be evaluating the data for completeness and conformance as per the 3 terms I described earlier. And then going through, confirming, cleaning, and revising the data set. And in many cases, I would try to assess, and I'd find there's a field that was unreliable or I needed to pull more data, and then I'd go back through and repeat the process, again, checking for conformance and completeness, before I was able to eventually assess the measure and the data quality. So for this outline, the 3 measures I looked at were IRIS 23, IRIS 27, and IRIS 39. For each of them, I was trying to assess a different goal or topic. So for IRIS 23, I was looking at unstructured visual acuity data fields and how suitable they are for reuse. For IRIS 27, how useful the structured data fields are at representing surgery outcomes. And for IRIS 39, how unstructured IOP data fields, whether or not they were reliable measures of surgery outcomes. So the first of which I looked at is IRIS 23. This was looking at refractive surgery, patients with a post-operative uncorrected visual acuity of 20/20 or better. So the denominator for this measure was looking at all patients aged 18 years or greater with a diagnosis of myopia who underwent refractive surgery. So breaking this down, it's looking for surgery diagnosis, ICD-10 codes, procedure, CPT codes, and the age at surgery. So then from this data set, the numerator was patients who received refractive surgery with a post-operative uncorrected visual acuity of 20 or 20 or better within 30 days. So this was looking at exam data, visual acuity data, and visit dates. So if you're wondering what this actually looks like, if any of you have had eye checkups, you'll have likely encountered this chart where you have to read lines, and based on how far down you can go, you'll be given a visual acuity value. This is called the Snellen test. It tests for distance vision. So for example, if you could read to the 6th line and had a vision of 20/30, that means at 20 feet, you can see what a standard patient would be able to see at 20. So perfect vision would be 20/20. And so it's basically testing for sight at 20 feet. So if you look back at what the measure is actually looking for, it's looking for refractive surgery. So that's things like PRK and LASIK surgeries for patients who are trying to correct their vision, their distance sight to be better without the use of a vision aid, such as contacts or glasses. And so it's of these patients who are trying to improve their vision, how many actually achieved a visual acuity of 20/20 or better? So how did the vision actually improve for these patients? In going about assessing the visual acuity, there are many different fields to do so. There are both corrected and uncorrected visual acuity entries for either both eyes together, eyes separately, and things such as pinhole and manifest values, which aren't as relevant for this measure. The values that I primarily focused on were for the uncorrected for both eyes and for the left eye and for the right eye individually. And so this data over here is the poll from the visit dates for all patients with refractive surgery. And this is the data that was recorded on both eyes visual acuity test. And as you can see, a vast majority of the data was actually missing. And of the data that was there, none was in an unusable format. The second largest chunk was proper data, and the second was potentially usable data. I'll talk about more what that looks like in the actual data fields later. For both the left and the right eye, the data was much stronger, with a vast majority of the data actually being in a proper usable format, with a larger percent being potentially usable and a small percent, only about 9%, being unusable. So for this data field, over 90% of the data was actually able to be converted and used in calculating the measure. The results were about the same for the right eye, with only about 8.5% being unusable. Again, over 90% that was able to be included in the metric. So when compared together, it's clear that a majority of the providers in follow-up visits only checked in one eye, typically as only one eye was operated on most of the time. However, the procedures could either be bilateral or on each individual eye, So this posed a challenge in how to actually calculate whether they had a visual acuity of 20/20 or greater. So for patients in which one eye was operated on, I looked for if in 30 days after their surgery, if they had a visual acuity that was less than 20/20. And it was just if any value out of all the time was less than 20/20, if it was above for the rest of the month but only down once, it would still pass the metric. And as such, the metric highly favors the providers, as most clinics want their providers to succeed. The issue came when assessing bilateral surgery, so when it was on both eyes, as a vast majority of the both eye data was missing. So in this case, if there was a value in 30 days that was 20/20 for both eyes, they would pass. And then if that wasn't the case, then it would look for if there's a value in the left eye or the right eye that beat 20/20. That would also pass the metric. So this is only one of the first challenges in assessing the data quality measure. The main problem with this issue was in the denominator requirements in the measure's diagnosis codes. The diagnosis codes they had given were supposedly CPT codes, but they were actually mislabeled HCPCS codes, which is just a different type of recording format. So if you were to literally examine the denominator as it is written, then there would be no data able to be collected on the field due to the fact that you would never find a CPT code that had a HCPCS codes label. So to get around this, we pulled unlisted CPT codes for refractive surgeries and only filtered LASIK and PRK surgeries. The second shortcoming in this measure is in the numerator, as that it's testing for visions above 20/20. And some of the cases where patients are going for bilateral refractive surgery, they may not be looking to have both eyes corrected for distance. One eye may be for distance and one eye might be for reading. So it's not necessarily the appropriate measure that both eyes would be hoping to have a value of 20/20. Similarly, there's also plenty of challenge in reporting the actual visual acuity values themselves. As they're free text, the providers can enter whatever they would like, and as such, there were a variety of issues with the input, specifically as in shorthand values. So things like CF would be count fingers, and then the number would specify how many feet, so count fingers at 1 foot. If there's 5, it would be at 5 feet. And NLP or LP are things like no light perception, light perception, which are difficult to convert into a Snellen format, so 20 out of 20-something, as there's no way to do that. But in terms of this measure, they would automatically be excluded, as count fingers and light perception are tested if the patient can't view any of the letters on the Snellen chart. So they'd automatically fail. And hopefully, if someone was going for a refractive surgery to get 20/20 vision, they would come out and be able to see light or count fingers. It'd be a pretty negative outcome if that were to happen. Similarly, there were typos within the text fields, things like 20/20, and as it was not as straightforward as an input as a specific word or letter, it was kind of a complicated input. There would often be mistyped letters such as $signs, exclamation points within the field that made it very difficult to actually count what they were trying to write. Similarly, there were things like unable, which was unclear whether or not the provider was unable to actually do the test or whether the patient was unable to see any of the letters. And similarly, there were entries that just were like upset as if the patient was having a bad day and was not in the mood to do a visual acuity test. Additionally, some measure-specific issues that I encountered was when I had to decide between NT and NA. If a value was entered as NT, then meaning not tested, whether that should be included as unusable data or missing data, as there was no data technically there. I decided that since the data was inputted into the field, then it would be considered unusable in an unusable format. Some other issues that I encountered was in 20/20 BLC, which would be bandage contact lens. So if the patient was coming out of surgery and they had damage to the eye, a contact lens that had no prescription would be put on them just to help their vision. This had to be cleaned up into a usable format, getting rid of the additional letters. Similar things like 2015 with a -1 or a +1 signifies the patient could read the letters on the 2015 line, but a -1, they missed a letter, a +1, they could read a letter on the next line, and so forth. Additionally, there were comments such as hazy, slow, or soft that couldn't be quantified, so they just had to be cleaned off the data sets. So when looking at the actual quality metric, a vast majority of the providers actually were able to get their patients a visual acuity of 20/20 or better within 30 days. However, this may be boosted along by the fact that it is particularly easy to get that value, as they only need to have one eye seeing 20/20 or better within that period. And even out of the 15 that failed, 2/5 of that only failed because they were missing or didn't have usable data. But this isn't necessarily representative of the outcomes of the surgery, because as I said, some may be correcting for vision and for distance, or for distance sight and for close distance, and it's possible that providers after the surgery were favoring their patients a little more, as if they were halfway through a line, they would just give them the next visual acuity, or they may have scooted the chair an inch or two closer, just give them a slight edge in the test. So when looking at the visual acuity data for IRIS 23, it's clear that only the primary uncorrected visual acuity data set provides reliable data and results, and that a vast majority of the other measures, such as the both eyes data, pinhole, and manifest values, were missing in a majority of the time, so they wouldn't provide reliable scientific evidence to be used for research. So the second measure I'm looking at is IRIS 27, which is looking for adverse events after cataract surgery. The denominator is looking at patients aged 18 years and older with a diagnosis of cataract who had cataract surgery. So it's pulling data fields of age at surgery, procedure, the CPT codes that are listed. And the numerator is percentage of patients aged 18 and older with a diagnosis of cataract who had cataract surgery and the following complications within 90 days. So prolonged inflammation, incision complications, and so forth. This is looking at visit date and surgery codes. So in calculating this, since I was looking at diagnosis codes, it's a structured field, so there's more limit as to what can be inputted, and you can't really take, it'd be impossible to analyze the codes as either potentially usable or incorrect, so they have to be taken at face value that all the data is actually in an accurate format. So a vast majority of the data was actually present and usable in this data set. However, although the data was quite simple, there were a lot of issues with this in the actual calculation of this measure itself, the primary of which being defining the numerator's adverse events. It was listed in the procedure, it just has a list of prolonged inflammation, incision complications. It's kind of difficult to quantify what that actually means in the EHR record. So initially we had pulled the data from the visit notes, and we're looking for signs of providers updating these complications as they're in there. And combing through thousands of data sets, that was incredibly time-consuming and difficult, as the display is often quite cluttered and difficult to sort through. So we looked for a better way to do this, and we actually reached out to the moderators at IRIS 27 of the measure, and they provided us a list of ICD-10 codes that we could look. So this was a case in which we had to go back to the EHR and pull a new set of data and then reprocess it looking for the codes. And so similarly, once we did that, we found a numerous amount of cases that were easy to sort through, and you could mainly set up code to do that instead of having to look by hand. And of those 20-something cases that actually had the adverse events, I looked through the notes and only found one of them where it actually mentioned the complication in the note itself. And I did a sample of another 80 random notes to see if there was mention in them, and I found no notes. So it's safe to assume that this data is fairly plausible. However, another issue with this measure was in the time frame. Since it's a 2019 measure, it's only reporting for the 2019 year, and it has a 90-day requirement in the numerator. So the measure is specified to only include procedures performed through September 30th, which obviously from any data analysis standpoint is a huge issue, as that's missing data on a quarter of the year. So any results from that time period would just be discarded. However, when looking at this measure, it's clear that a vast majority of the patients failed, which in this case is good, meaning there were no adverse events after surgery. And this data was actually one that I was able to check for plausibility, as according to the American Society of Cataract and Refractive Surgery, there are about 30 million of these surgeries a year, and they generally have a success rate of above 98%, putting this metric success rate at 98.9, right within that range and into the reasonable, acceptable data standards. So when looking at this field in itself, the structured data fields, it's clear that structured data has a much more reliable representation of surgery outcomes and has a much better potential use for data. Which then brings me to the last measure that I looked at, which is IRIS 39, which is looking at glaucoma, intraocular pressure, reduction following trabeculectomy or an aqueous shunt procedure. So the denominator is patients 45 and 85 years, diagnosis of various types of glaucoma who underwent these two procedures. So you're looking at the age at surgery, the diagnosis codes, procedure, and visual acuity values, because the visual acuity was in a denominator exclusion, so patients who were at the stage where they were counting fingers or perceiving light, they were left out of the study. So the numerator was actually looking for these patients to see an IOP reduction of 20% from the pretreatment values, or an overall reduction in the number of glaucoma medications. A modified version of this measure was actually released a couple years prior to, and it hadn't included anything about the number of glaucoma medications. And they found that with this disease and treatment, it requires a particularly nasty blend of medications, as in multiple different eye drops multiple times a day. And so patients were actually going to get this surgery just to reduce the number of drops they had to take on a daily basis. So this measure is looking at pretreatment visit dates and IOP values. Now, basically what this measure is assessing is interocular pressure, which is the pressure within the eyeball. And high pressure within the eye can lead to eye damage. And that brings us to what glaucoma is, which is basically blindness induced by high pressure within the eye. So these two procedures are meant to drain fluid from the eye, therefore reducing pressure. And it's testing if this actually helped to reduce pressure in the eye, or the patient saw a reduction in number of medications. So when looking at this data, it was sort of similar to the left and right eye values for visual acuity. A vast majority of the data was present. However, a larger percent between 16 and 17 for the two measures was either in a missing or unusable format, with a lot less being potentially usable. There was less wiggle room in what could be entered into the data set. This was similar for the right eye as well, with the vast majority being useful. However, combined for the fields, after being cleaned and processed, only a little bit above 80% could actually be used in calculating the metric. So, for evaluating this metric itself, it's quite difficult to assess the reduction in overall number of glaucoma medications. As if anyone's familiar with the medication section of EHR, it's quite cluttered and difficult to assess, as sometimes patients don't know precisely what medications they're taking, or they may have stopped taking some, or they're just not taking it in general. It's quite difficult to report exactly how much there is, and specifically assessing decrease in the number of glaucoma medications, as in many cases there are transfers of one medication to another if patients didn't like the medication or had some sort of reaction to it, that would be switched, as well as cases in which a more frequently low-dose medication was being switched out for a higher power, less frequently taken medication, and whether or not that counts as a reduction in glaucoma medications. Additionally, when assessing IOP, there's high fluctuation between IOP values, as depending on when the patient took their medications or just day-to-day, week-to-week, it can fluctuate highly. A patient with an IOP within the 30 range could just 1 week or 1 day have an IOP that drops down to the teens, making this metric difficult to assess, as within a 30-month period you could have IOPs fluctuate even without surgery, above or below 20%. Additionally, it was intensive manual calculation to go through and look at every single note to see whether or not there was reduction in medications and processing what medications were actually reduced. Looking at the measure-specific IOP field, it was a lot less difficult to assess than with the visual acuity fields. However, there were still interesting values such as 0, which would be incredibly unlikely to find unless the value is taken immediately after surgery and there's almost no pressure in the eye. Similarly, a pressure of above 30 is considered high pressure, so a value of 43,000 would cause some serious questions as to the pressure of that eye. And data frames such as entries such as 0 to 1 are difficult to actually put a number on, so I would just set those to be 0.5. And additionally, there were cases in which there were multiple pre-treatment IOPs, so in that case, I would just take the average of the two, as there is high fluctuation. That's the most reasonable result. So when looking at the actual metric itself, a vast majority of the patients failed, rather compared to the ones that met the criteria. But this failure is not actually representative of the data, as because a majority of the patients who failed, almost 83%, only failed because they didn't have proper data. And that's because this field is so specific, requiring pre-treatment IOPs, diagnosis, and procedure codes, as well as visual acuity reading for that IOP on that eye that was measured 3 to 4 months after the surgery. So just due to the nature of this criteria, it was very difficult for patients to have correct data in every single one of those fields. Additionally, for meeting the 20% fluctuation, it only needed to be met within that 90 to 120 day period, 3 to 4 months out, and just due to the high fluctuation variance in IOP values, it's possible that could have just been coincidence rather than any actual effects of the procedure. So, in conclusion on this measure, although present, high fluctuation in IOP values leads to unreliable outcomes, and so if looking at these values in scientific research, it's less of a strong indicator of surgery outcomes and more of an indicator of just the fluctuation in the nature of the field. So looking to the future, improving clinical quality measures and data quality. So EHR data at this point has a reputation for being poor quality, having completeness, consistency, and correctness issues. And this can be broken down. The solution to fixing this maybe looks at, on the clinical level, by division, departments, seeing which providers, which divisions, and so forth have consistency or conformance issues, comparing results and reviewing solutions. So potentially getting specialists to look at EHR, what the issues are, what's causing them, and then proposing changes to the EHR interface itself, such as user interface changes, potentially implementing quality monitoring or cleaning tools. Additionally, potentially just training providers better on how to enter data consistently and correctly, as well as a feature just for the quality measures is they should be structured precisely, using available structured fields and specific vocabulary to indicate exactly what we're looking for. Additionally, an issue with this data is that there is an intrinsic sick bias, as patients that are sick or injured are much more likely to be in the hospital, and therefore there's much more data on them than there is on healthy patients, skewing results further that way. So in summary, EHR data has promising potential for secondary research. Shortcomings within the EHR systems can lead to data quality issues and therefore less reliable results for research and clinical studies. And it's quite difficult to evaluate EHR data plausibility as there is no gold standard. The closest thing to compare it to is paper records, and even then, those aren't necessarily correct or complete. So then careful definition of quality measures and research questions combined with modifications to EHR interfaces will improve fitness in EHR data for secondary use. So look forward to the field revising the EHR, revising measures to actually have results and outcomes that can be analyzed within the data fields as they are currently present. So I wanted to thank Dr. Chang and HIPAA for this incredible opportunity for summer research and everyone else helping in the project. It was a great experience with the summer, and I learned a lot. Thank you. What I thought was interesting was that even based on providers for specific fields in the free text, there's a lot of variation. So whereas one provider may have, it's not like one provider has one type of error over and over again, whereas inconsistent formatting, the provider's formatting ranged from complete to all varieties of inconsistent for almost every single provider. So it's not necessarily just an issue of putting on the blame on a few providers or a few divisions that haven't been necessarily as strict with their implementation or consistency or formatting. It's that a lot of the providers just, in certain cases, maybe mistype characters or just miss things, and the formatting just needs to be standardized, is what I'd say.
Yeah, I guess it's probably more of a comment than a question, but maybe have a response to it.
Mm-hmm.
Your work, well, it exemplifies a lot of shortcomings in data. There are people who think that, we don't need to do controlled research anymore. We just look into the electronic health record. But, as we, as a society, and this goes beyond medicine, as we use data for all kinds of things, whether it's social media data or whatever, it just shows that oftentimes the data that we have is very contextually dependent on how it's collected and what we collect and so forth, which leads to bias because we don't necessarily have all of the data. We only have the data that we've collected. Yeah. But your findings kind of verify that sort of thing.
Mm-hmm.
Michael, I have a question to follow up on what Bill said. I think it's very easy for people who make laws, like the policymakers, to assume that, well, because we've got the data electronically, that it's going to solve all of our problems and that we'll be able to just use that data to figure out sorts of things. And, what I've taken away from your findings is that it's not so easy. In fact, it often doesn't work that way. And I'm just curious if you have a sense. Do you think this is going to work like 5 years from now? Like, do you see us sort of being able to use these? Because, we've got this plan to pay doctors based on data that's calculated through metrics like this, but if it doesn't really work, like, how are we supposed to pay doctors? And I'm curious if you have a sense, just from having spent, in all of your 6 weeks, of experience with this, if you have a sense of, do you think this is going to work or not?
Yeah, I think in the long term this will actually be a very valuable data source, but in the meantime, just because it's relatively new and providers and clinics may not be super familiar with how the data can be used and applied to research and the formats it would need to be in, consistency issues, that it's going to take a while, and it's probably going to be on a provider to clinic basis of that they're going to have to actually implement the changes themselves and work on specifying the data and making sure all these fields are accurate and precise. And as well as even before that can happen, there needs to be a more generic and well-known framework for actually assessing the quality of the data that they're inputting. But I believe 5 years is probably pretty short, but sometime in the foreseeable future, this data will definitely be extremely valuable to all areas of medical research.
Yeah, Mike, I think it's interesting, just from a philosophical perspective, we often teach the students and the fellows in this department that informatics, the field of biomedical informatics, isn't just about the technology. Mm-hmm. It's about, how do you, set up processes, to take advantage of that technology, and how do you get people to do it? And so it's a little bit of, almost a little bit of sociology and economics. And I think this is a really interesting example of that if people don't really do it, then the technology doesn't work in isolation.
Yeah, exactly.